Hi, this is Doug Rex with the ASGE colonoscopy tip of the week. Last week we talked about the technique of tattooing during colonoscopy. Today I'm going to talk about some of the principles of localization with tattoos. So first, if you're tattooing a lesion that you're going to refer to another endoscopist for resection, don't put the tattoo under the lesion. That's been reported to possibly increase the risk of perforation from tacking the layers together. So tattoo, for example, the opposite wall or a site a few centimeters distal to the lesion on the same wall, and then make a note of that location in your report. When you're tattooing one of your own EMR sites, put the tattoo right next to the site and then just note the location in relationship to the polypectomy defect. An EMR site can just be marked along one edge. The stick is typically simple, just into the pre-existing submucosal injection bleb. And then in the report, mark where the tattoo is in relationship to the site, proximal, distal, right, left, etc., so that at follow-up, it's easy to find the polypectomy scar. With regard to tattooing for surgery, if the lesion's in the cecum or the ascending colon, you can still see the cecum on the other side of the lesion. I don't think tattooing is necessary because that's an endoscopically reliable position. The patient needs a right hemicolectomy. Once you can't see the cecum anymore and down around to the rectum, it's best to tattoo. I like to tattoo just distally. Some tattoo both proximally and distally, but I think it's less confusing to just have the tattoos in one location and then note in the report where you have them. Use good technique, as was discussed last week, in a large volume so you keep the tattoo out of the peritoneal cavity. Mark the lesion well. Remember, when you're between the hepatic flexure and the rectum, that the whole purpose of tattooing is that we never know for sure where we are. So don't designate precisely a section. Rather, force the surgeon to locate the tattoo in the wall of the colon, say approximately in the descending colon, so you don't imply, if they can't find the tattoo, that they can reliably remove one particular section. That's the whole purpose of tattooing. Here's a patient who's had endoscopic resection of a probably malignant polyp, and we're tattooing for the possibility of surgery. So we want to tattoo the entire circumference, use a large volume, in this case about 15 cc's divided into 3 large submucosal blebs. From time to time during the tip of the week, we'll talk about some issues that are relevant to avoiding malpractice risk. Localization during colonoscopy with tattooing is one of these issues. If you send a patient to surgery and the wrong segment of colon is removed, then both you and the surgeon may be at risk for a malpractice action, particularly if the patient alleges some symptoms because of a more extensive resection than would have been otherwise required. So make sure that your surgeon and your partners who are covering for you understand that if a patient is in the OR and a tattoo can't be found, you want to be called. You'll come to the OR and do intraoperative colonoscopy to localize the lesion and make sure that the correct segment is resected. Of course, the most effective way to avoid this situation is to use good tattooing technique. Get it into the submucosal space and put in a sufficient volume that the tattoo will be easy for the surgeon to find. Remember that when you refer a patient to surgery, that both you and the surgeon have a responsibility to make sure that the correct operation is done. So use localization effectively. That's the ASGE colonoscopy tip of the week. The tip of the week is brought to you by an educational grant from Braintree Laboratories.